Dr. Mary Sebelik is joining us this morning to speak on a very innovative and new technology, the role of radiofrequency ablation in the management of thyroid nodules and possibly cancer. Dr. Sebelik is a professor in our Department of Otolaryngology, Head and Neck Surgery, and serves as a head and neck surgeon at our Atlanta VA hospital as well. She received her medical degree and completed her otolaryngology residency at the Medical College of Wisconsin. She then completed her head and neck surgical oncology fellowship at MD Anderson Cancer Center in Houston. Dr. Sebelik's clinical practice has an emphasis on endocrine surgery of the head and neck. She has incorporated surgeon-performed point-of-care ultrasound into staging, treatment planning, and preoperative surgical assessment. She's also a sought-after instructor on the national and international scene for ultrasound education. Dr. Sebelik was granted and awarded the prestigious American Academy of Otolaryngology Head and Neck Surgery Distinguished Humanitarian Award in 2020 and was elected to the prestigious Academy of Master Surgeon Educators of the American College of Surgeons in 2021.
Hello, my name is Mary Sebelik, and I am delighted to participate in the updates and management of thyroid cancer. And thank you for joining us for our virtual symposium. I am an endocrine surgeon at Emory University Winship Cancer Center, and I have no disclosures, and I am delighted to be able to discuss today the role of radiofrequency ablation in the management of thyroid nodules and cancer. So the outline of what I'd like to talk about today is briefly a description of radiofrequency ablation, a little bit of its history, the basics in its technique and expected outcomes. But more importantly, I'll focus on patient selection for this procedure in the context of benign thyroid nodules, as well as the potential use for patients with recurrent papillary thyroid cancer in the neck and patients with low-risk primary papillary thyroid cancer. So a little bit about the history. In 2017, which I'm showing here, the most recent guidelines out of the Korean Society for Thyroid Radiology was published, which is a comprehensive review, evidence-based review that's allowed the rest of the world to really mirror some excellent guidelines. In 2009, radiofrequency ablation for benign thyroid disease was really started in Korea, and the first set of good guidelines was published in 2012 by the same body. As I said, the follow-up to that was published 5 years later, and very soon thereafter, in 2018, the United States FDA issued device approval for radiofrequency needles appropriate to thyroid pathology. Very soon after, thyroid interventionalists in the United States started offering this to patients, and patients really started embracing this as a treatment modality that included endocrinologists, interventional radiologists, and surgeons. And in fact, in 2021, the American Thyroid Association planned update on management of thyroid nodules will include a robust section on the evidence supporting radiofrequency ablation. The most important statement at the end of this guideline paper for me as a surgeon was this pretty strong statement that radiofrequency ablation is and should be a wake-up call for surgeons. So the basics, what is needed to perform this procedure? Well, first of all, you need the right patient. So the patient would be someone who has the appropriate disease and indications. It needs to be a willing patient, one who is motivated to avoid operative treatment. And over here on the right are some photographs, including a pretty large multinodular goiter pulled out through a pretty stretched small incision. And even further is a photograph from a recent petition put forth by patients who really want to, quote, change this or avoid neck surgery and neck incisions for treatment of thyroid disease. It needs to be somebody who is also willing to undergo a procedure under local anesthesia. This also may include a body of patients who may be too sick for surgery or for whom surgery is too high risk for anesthesia purposes. It needs to be the right clinician, somebody who has training, somebody who is comfortable with ultrasound-guided interventions, which could include an endocrinologist, a radiologist, or a surgeon who is experienced in ultrasound-guided procedures. You need to have excellent ultrasound imaging, both access to this at the outset to properly assess the patient for fitness for this procedure, but also ongoing for continued imaging surveillance. You need a radio frequency generator. So this piece of equipment has existed for many years for other organ systems. The technology itself is not new. However, what is new is, or newer, is the needle that's manufactured directly for neck structures and thyroid glands. These are typically 18 or 19 gauge needles with the appropriate length for neck structures. Well, what else is needed to perform radiofrequency ablation? You do need training, and this is a photograph of me with a little side-eye glance. I was very lucky to obtain training in Brazil with some world-class instructors, but this training was at the very end of January 2020, and at that moment, I don't think any of us had any idea what was in our near futures of the impending global pandemic. And I did not realize at that time that this would severely hinder our ability to start an RFA program at Emory Winship. But I was very privileged to get into this level of training. Well, the technique itself, this is a very superficial overview. The technique first involves getting your patient comfortably in a supine position and injecting the structures with local anesthesia that will help minimize discomfort. And this includes the skin overlying the thyroid gland, the underlying strap muscles, the thyroid capsule over the isthmus and around the lobe that has the pathology, and the expected path of the needle. Then after that, the zone around the lateral and posterior border of the thyroid gland is injected with either dextrose and water or saline for hydrodissection. And this introduces a zone of fluid around the thyroid gland that pushes the structures to the side and creates a heat sink or an insulator to keep heat or thermal damage to the adjacent structures. The thyroid nodule is approached from the contralateral side across the isthmus or via the transisthmic approach. And this provides clear anatomic landmark visualization with ultrasound. It prevents back leakage of the hot liquid out around the thyroid gland. It produces stability if the patient feels he or she needs to swallow or cough. And it certainly avoids the danger triangle. That's the critical tracheoesophageal groove that contains the recurrent laryngeal nerve. The moving shot technique is a descriptor of the creation of ablation zones from deep to superficial, from posterior to anterior. And the reason for this moving shot technique is because the ablation immediately creates a temporary hyperechoic zone past which you can't see on ultrasound. So you really need to start away from you and work back toward yourself. And then once complete, the patient is discharged with an ice pack and very minimal analgesics, and they can go back to their normal activities. Well, what are the effects of radiofrequency ablation on ultrasound? Well, we know that post-ablation, after the immediate hyperechogenicity is noted, the nodule becomes intensely hypoechoic. It loses its internal and perhaps peripheral vascularity, and it becomes more dense and less elastic. And also, we hope it becomes smaller. Success for radiofrequency ablation of benign thyroid nodules is measured as, number one, relief of the patient's symptoms, and number two, a reduction of the thyroid nodule size by greater than 50%. There are side effects and complications, but they're unusual. The Korean Society of Thyroid Radiology did study a body of over 1,400 patients and noted that the complication rate overall was a little over 3% with 1.4% observed more severe complications. And this included temporary hoarseness. And in fact, the advantage of having an awake patient during the procedure is if the patient does note a change in the voice, the provider can pull back or abort the procedure and change technique. There can be some slight bleeding and swelling at the injection site, and actual clinically significant bleeding is highly unusual. Wound infection is highly unusual. There can be vomiting and coughing, and there can be burning of the skin at the needle injection site. However, this can be prevented by meticulous technique. Patients with autonomously functioning nodules, which is one of the indications for this, can rebound and have hypothyroidism following the procedure. So let's move on to patient selection, because this is the gist of this of this technology is proper patient selection. So the most evidence and the most history is the use of radiofrequency ablation for those with benign thyroid nodules. And these are some photographs of one of the big reasons patients might desire this treatment is that large thyroid nodules can be cosmetically deforming to the neck. And those are some photographs of before and after radiofrequency ablation to show that you can truly reduce the size of the nodule so that the neck contour returns to normal. But patients also note compressive symptoms such as pressure on swallowing, tracheal deviation, and positional feelings of breathing restriction, may have some change in voice, although actual vocal cord paralysis is unusual with benign nodules. And once you have a patient who has complaints, either compressive or visual or both, then the patient must undergo a risk stratification of their nodule, just like any other nodule patient. And you will likely recognize the ATA guideline ultrasound risk ladder at the top of the slide, and the TIRAD scoring system at the bottom of the slide, which helps really hone in on who is at risk for a malignancy and who's not. However, it is important to note that even if you have a very low risk appearing nodule, the 2017 Korean guidelines do strongly recommend with medium to high evidence levels and strong recommendations to undergo at least one benign biopsy. And in fact, if there is any appearance of the thyroid nodule beyond the lowest risk appearance, there should be 2 benign biopsies. If it's a low risk appearance, there should be 1 benign biopsy along with documentation of the low risk echogenicity, or if the patient has an autonomously functioning nodule and 1 biopsy, this is sufficient to meet criteria for radiofrequency ablation. These strong recommendations with pretty decent evidence are followed by virtually every other guideline that has been distributed for radiofrequency ablation. And this is a nice study that compares the guidelines put forth in Korea, Italy, Austria, and the UK, all echoing the same guidelines. A symptomatic patient who should have 2 benign biopsies, or if has very low risk echogenicity, 1 benign biopsy, or if there is an autonomously functioning nodule and 1 benign biopsy meet criteria. And more recent publications include the 2020 European Thyroid Association guidelines and the 2021 seminars in interventional radiology guidelines out of Virginia and Oregon Health Sciences support the same thing, appropriately symptomatic patient with the same level of proof of a benign nature of the nodule. So great. What about the patient who already has a history of papillary thyroid cancer and may have a recurrence in the neck? So this is something that has been looked at for the use of radiofrequency ablation. And this guideline listed up in the top of the slide, which has a strong recommendation with a moderate level of evidence, is that radiofrequency ablation can be used for that patient who is desiring curative or palliative treatment for their recurrent cancer in the neck. This can be in the thyroid bed or the lateral nodes, and the patient either is at high risk for additional surgery or may be refusing surgery. And these ultrasound images are those of a patient who has a recurrence in the neck after several surgeries and treatment. And in fact, this particular patient is a 75-year-old who first underwent treatment for her papillary thyroid cancer in 2015 with a total thyroidectomy and nodal dissection. She was noted to have a tall cell variant of papillary thyroid cancer and underwent post-operative radioactive iodine. Her post-ablation scan was negative, but unfortunately, in several years, she developed a recurrence in the neck. She underwent a pretty extensive neck dissection, which extended to the pharynx and into the upper mediastinum, and she required a pharyngeal repair and a period of time without oral intake. So this was a pretty devastating procedure for her. So when she then developed another recurrence in the same area, her level of frailty and she was exhausted with any further surgery. She really refused any further surgical treatment. So she was actually deemed the ideal candidate for some kind of local treatment that was non-surgical. And in her case, the ablative technique of ethanol injection was chosen. And these are some pictures of her ultrasounds. This is the very indiscreet or shaggy neck recurrence that she was noted to have near her carotid sheath. And you can see the red line is the needle approaching this mass. And this next picture includes the hyperechogenic zone that can be seen with alcohol injection. Thank goodness, over time between her first measurement and her post-ethanol ablation measurement, she was noted to have over a 70% reduction in nodule size. So this has been studied, comparing radiofrequency ablation and ethanol ablation as equivalent techniques. And this systematic review of a number of studies looking at ablative techniques for recurrent cancer included studies that reported volume reduction or disappearance of the disease, changes in levels of thyroglobulin, recurrence rates, and major and minor complications. And this noted that both radiofrequency ablation and ethanol ablation are acceptable treatment modalities to manage locally recurrent thyroid cancers in terms of efficacy and safety in patients who are poor surgical candidates or refuse further surgery. In 2019, a good review of ethanol ablation specifically was published for neck metastases. And it was noted that although the preferred therapy for local regional recurrence is surgery, ethanol ablation can be considered for select patients with unresectable, non-radioiodine avid, and or progressive papillary follicular and Hürthle cell cancers. Even in the 2015 ATA guidelines, this therapy was alluded to that it may be beneficial in select patients. Well, how about another type of thyroid cancer patient? And that is the patient who is diagnosed up front with a low-risk papillary thyroid cancer and has not received any therapy yet. So what is the role of radiofrequency ablation in this patient population? We know that some low-risk patients may be very good candidates for active surveillance, and I'm going to review some of the criteria for consideration of active surveillance. And we know that the lowest risk patients maybe have excellent outcomes, but that prediction is based on location and size of the nodule based on access to really good ultrasound to create the basis for making this decision, and that all stakeholders, most importantly the patient and family, as well as the treating physicians, are involved in this decision making. So if you have a patient who may be an appropriate candidate for active surveillance, such as this patient with a very well-defined small sub-centimeter papillary thyroid cancer, if the patient is a good candidate for active surveillance, consider radiofrequency ablation as a more active or more aggressive form of addressing the cancer. It is estimated that over 50,000 patients may be diagnosed over the next 5 years who have such low risk papillary thyroid cancers that active surveillance can be a very safe and effective treatment strategy, which would then eliminate the cost and risk of surgical intervention, the more traditional therapy. So let's again dive into the criteria for active surveillance a little bit more by looking at Brito's Brito's publication on a nicely done risk stratification for active surveillance. And this busy slide is there to review that we need to look at the tumor, the patient, and the treating team characteristics to help make this decision. So in summary, the ideal candidate for a patient who could undergo active surveillance or non-cancer treatment is that willing patient who's older than 60, may have comorbidities, has a well-defined single nodule without extrathyroid extension, and has an experienced team with easy access to high-quality ultrasound. The appropriate patient may be the patient who's between 18 and 59, may have a history of thyroid cancer in the family, may have a multifocal or ill-defined nodule or an FDG avid nodule that's picked up on surveillance for another type of cancer. I see a fair number of patients referred to me who have head and neck cancers, and they incidentally are noted to have an FDG avid thyroid nodule. And then we have to apply this kind of risk stratification to that patient. Also, this patient needs an experienced treatment team with available, easy access, high quality ultrasound. The most inappropriate type of patient is that patient with an extrathyroid extension of the disease, N1 disease, a growth greater than 3 millimeters in any one dimension over serial imaging, a patient who is younger than 18 or may be non-compliant, and especially a patient without access to an experienced treatment team and high quality ultrasound. So if you take that patient who might be appropriate for active surveillance, but the patient and the treatment team may desire a more aggressive approach, we need to look at the role of the interventionalists and really look at whether radiofrequency or alcohol ablation is a great intermediate option. So here's a patient of mine. This is a really good example. She's a lady who is 82. A healthy female, lives in an assisted living facility, and she had an ultrasound of her neck for vascular disease and was noted incidentally to have a just around 1 centimeter nodule in her thyroid. And you can see on ultrasound, it's actually very hypoechoic, or because the anterior surface is covered with some broken eggshell macrocalcification. This was proven to be papillary thyroid cancer on FNA, and the patient was deemed to be a very appropriate candidate for active surveillance because of her age and low risk nature of the papillary cancer. She actually adamantly refused. She wanted to, quote, do something to treat the cancer, unquote, and it was unacceptable to her to simply watch the cancer. So she did undergo thyroid lobectomy very uneventfully. Her tumor turned out to be 1.1 centimeter in greatest dimension, and all the surgical resection margins were negative. So she went on back to her active lifestyle. But she did undergo a surgery to do this. So in my practice and in my market, I have many patients who, even though they're really good candidates for active surveillance, they simply don't want this. They want to be more aggressive. So the patients who do fall into the active surveillance mode for my practice are the very elderly and frail patient those particularly who may be suffering from another higher risk or more lethal cancer or comorbidities, and then that small select group of patients who are simply postponing surgery because of a temporary condition such as pregnancy. So what if we had something intermediate for these patients, not as aggressive as surgery, not as non-treatment as active surveillance? And there are some great recent analyses of this question, and this is a nice publication out of this year, looking at ultrasound-guided radiofrequency ablation with direct comparison to thyroid lobectomy for the very low-risk microcarcinoma. And this studied a group of 884 patients. And it was noted that over a 72-month observation period, radiofrequency ablation versus thyroid lobectomy was statistically equivalent in tumor-free progression. You can see there's a little bit of difference between the purple and blue lines at 72 months out, but did not achieve statistical significance. The difference in complications, however, was much more striking. Radiofrequency ablation had a much lower observation of blood loss, complications, need for hospitalization. The difference in the time it took to perform radiofrequency ablation at about 3 minutes versus nearly 90 minutes for a thyroid lobectomy was striking. And then complication rates of injury to the recurrent laryngeal nerve or to parathyroid function was 0 in the radiofrequency ablation group and low but present in the surgery group. So this study showed in the microcarcinoma patient that recurrence-free survival was at least non-inferior for radiofrequency ablation, and RFA was superior to surgery for hospitalization, procedure time, blood loss, and complications. Well, what about the patient with a little bit bigger nodule, the T1B patient? So this also published in 2021, studied the patient with a nodule that may be between 1 and 2 centimeters in size. And this particularly stratified out the patients by age. And it showed that in the radiofrequency ablation chosen group of patients, and this is an interesting graphic that showed that while the nodule size increased temporarily after the first month after radiofrequency ablation, there was a steep reduction in nodule size, so that at 36 months, the nodule was close to 0 in size. And by that time, also, the difference between the older than 45 and younger than 45 age group approached the same reduction in size. Just as in the prior study, also, this RFA group was compared to the thyroid lobectomy group, and there was the same striking difference in complication, procedure time, and cost. So again, this study showed that RFA was equivalent to surgery in tumor control, but significantly superior to surgery in terms of complication, procedure time, and cost. So in conclusion, radiofrequency ablation has an abundance of evidence to support its use for benign thyroid nodule. It's very well established for this. And since the FDA issued device approval at the end of 2018, it's rapidly catching on in the United States, both because of enthusiasm by clinicians, but most strongly driven by patient desires. Radiofrequency ablation also has efficacy in the patient who has already been treated for papillary thyroid cancer and is suffering from a recurrence and is either too high risk or refuses further surgical intervention. And then thirdly, this should be considered as a treatment modality for the very low risk primary papillary thyroid cancer patient. We know that this low risk group of patients is a large group. The disease is frequently indolent, and if we can avoid the cost and complications of more aggressive therapy, RFA can be an alternative to active surveillance with avoiding the risks and costs of surgery. So I'd like to end this talk with a quote from one of our mentors and thought leaders in radiofrequency ablation, Dr. Lisa Orloff at Stanford, who is quoted as saying RFA may eliminate the need for most surgery for benign thyroid disease. And put in a broader context, the patients are asking for this as well. They would like to avoid neck surgery, neck incisions, and the risks of surgical intervention for benign disease. This is a wake-up call for surgeons and should be taken to heart by many of us who have a long history of performing surgery for benign disease. These are the references, and I do thank you for your time and attention, and thank you from our surgical team at Emory Winship Cancer Institute. And this is an illustration of the many professional groups of clinicians who are eager to give the best care to thyroid cancer patients. And thank you.